There we go. I'm going to try to touch
Yeah.
it.
And just one slide for context, because I think every state is very, very different. But in North Carolina, we have about 2.3 million children. Our state right now is in a particularly active phase where our whole Medicaid system and our state health insurance, child health insurance program are both in flux. As a state, we have applied for an 1115 waiver that would really help us move to being a true managed care kind of system. So for those of you who are familiar with 1115, we're sort of in that process right now. At the same time that we're undergoing Medicaid transformation as a state, we're really in the place where we're undergoing what I would characterize as child welfare transformation, moving towards a across our 100 counties. You who are familiar with the Family First Prevention Services Act, that's going to be a huge game changer in terms of service delivery, who gets services, authorization, and payment in our state. There is something that makes our state quirky that overlaps a bit with PCIT, and that is our behavioral emotional health services. 3 are not managed by our traditional managed care organizations. So in terms of service,
going for a while, and
in terms of service delivery, there is this sort of artificial break that happens on the kid's 3rd birthday. And then finally, in North Carolina, we have a really large military presence, so TRICARE is sort of a player in our array. Next slide, please. I am a co-director of a program called the North Carolina Treatment Program. We were established in 2006, and since 2013, we have been funded through our General Assembly as a line item in the state budget after a lot of legislative advocacy. I am the co-director. As I mentioned, I don't come from a mental health background. So my other co-director is Dr. Lisa Amaya Jackson, that many of you know from the National Child Traumatic Stress Network. But overall, what I would say in my elevator speech is that we at the Child Treatment Program consider ourselves an implementation platform for statewide dissemination of an array of child mental health treatments. Evidence-based treatments is really our goal, and getting them to all 100 North Carolina counties is also part of our mission. Next slide, please. In terms of our current array, TFCBT, PCIT, and CPP are models we focus on. Sparks is also a major area of focus for us, which is more of an evidence-informed model. And currently, after a 2-year study period, we are going to be bringing on statewide dissemination of a model for problematic sexual behaviors. And so this is sort of kind of our array that we're charged with disseminating. Next slide, please. The way we do our work is we really work with the clinical workforce as well as agency administration. We do training in terms of the clinical workforce, and we also provide technical assistance and other implementation supports to system of care professionals and to our statewide stakeholders. Next slide, please. What does that mean to be an implementation platform, and how do we think about operationalizing it? This is just kind of a quick list before we jump into the rate discussion. But we started out thinking we would just be this like training and coaching platform. All of our clinicians participate in a learning collaborative with us across our array of models. But I think what makes us unique in some ways is that our coaching platform is fairly intense. We do bi-weekly one-to-one calls with all of our clinicians during training, where we staff their cases fairly intensively from an integrity or fidelity perspective. And also in our program, clinicians have to demonstrate competence over at least 2 clients in order to graduate. If they are not able to demonstrate clinical competence in model integrity or fidelity, they don't actually graduate. In addition to our clinical implementation track, in addition to our clinical track, we are always running an implementation track that focuses on things like payment mechanisms, payment rates, etc. And so I think that's probably why I was invited to be on this call today. In addition to our training platform, we have recently launched in July a post-training platform. So these are ongoing activities clinicians are required to participate in every 2 years in order to remain active on our public roster, which brings me to the next item. I hate to show our web address now because we're just about to launch our brand new website, which is way better and loaded with tools and stuff. The current thing is kind of clunky, but on our homepage, what you'll notice is a big button that says Find a Therapist. We spend a lot of administrative time and dollars maintaining a list of all those who've graduated with us, keeping up with where their practices are, you know, the insurance that they accept, etc. So the idea is professionals and families are able to find trained, qualified clinicians. We also have been working behind the scenes. We have a beta version available of this web-based clinical support tool. We've been working on PCIT as sort of the prototype model, but basically it is an online tool to support training, treatment, monitoring, and reporting across an array of models. We also have sort of a different earlier version of TFCBT as well. And then finally, like I mentioned before, we do spend a lot of time talking to our state partners within Health and Human Services, mental health, social services, juvenile justice, etc., as well as agency level administration around how does one disseminate and then sustain these evidence-based practices. Next slide. In doing this work since 2006, we really ran into some barriers to EBT dissemination and sustainment. And, you know, the flip side, if you look at it more positive, areas that if one addresses, the likelihood of being able to support EBT dissemination increases. And so I'm sure many of you are aware of this, and probably that's why you're on this call. But in terms of our work across our array of models, we've noticed that Medicaid reimbursement rates are really not well aligned with the actual requirements of delivering the models with fidelity. That's a reality, and I can talk about any of these particular points and give examples if that's helpful at the end. We've also come across in working with our clinicians and our agencies that how coding and encountering is done is really not well aligned in the Medicaid world with how an EBT should be delivered. And then things like authorization and reauthorization procedures also are not really well aligned with the requirement of the EBTs themselves, creating sort of wasted administrative time and lost opportunities for increasing productivity. Next slide. So within our program, our thought several years was, as much as we'd like to exclusively spend our time training and working on clinical competency, in order for our trainees and our graduates to be able to go out in the world and sustain their work, there needs to be behind the scenes advocacy. So we are not a governmental agency, although we are funded directly by our General Assembly. We're not a research shop, although we have researchers that work for us. We see ourselves as public mental health infrastructure. So necessarily we see that there is a role in supporting agencies to secure appropriate reimbursement. So really our dog in the fight is that we want to help support high fidelity, outcomes-driven EBT delivery in the community, but also in restricted settings like psychiatric residential treatment facilities or juvenile justice facilities. Next slide. Our efforts have really been around securing cost-based reimbursement rates, clinical services that go along with EBT delivery. We recognize that there are activities that happen physically in the room between a parent and a child and a therapist, but a lot of effort actually happens in that treatment room. That's also critical to the success of model delivery and also achieving the outcomes that are the desired outcomes. We also, in terms of working around cost-based reimbursement rate issues, we also have advocated to sort of secure better encountering, coding, and billing practices that are aligned with what the actual EBTs require. And then finally, there's this other piece that goes along with that, and that's advocating or educating around what authorization and reauthorization could look like in a clinically driven world rather than just like a compliance-driven world. Next slide. When I say advocating, what that means is we, within the child treatment program, our faculty and staff, we speak to the Division of Mental Health, the division that houses our Medicaid, juvenile justice. We speak to the managed care organizations. We present data, and we argue that if you have a workforce that's well trained and they understand that they're required to deliver high fidelity treatments that's clinically competent, and that the ultimate goal is to achieve clinical outcomes, if you have that workforce, they are the ones who should be, receiving a rate that is cost-based, that actually supports their work so they can keep their doors open. And so the folks that we actively speak out on behalf would be anyone across our array of models who are nationally certified, as a model developer would recognize it. We advocate on behalf of our active trainees, and that has not been a really hard thing to sell in this state because our coaching platform is so intensive in terms of biweekly consultation that we know that these kids are getting excellent treatment even during the training phase. We obviously would be advocating on behalf of our graduates, folks who have graduated from the program and for whatever reason are not engaging in our post-training platform. And then there's this last category since July where we have in PCIT and across our array a support platform of active clinicians that we would also be advocating on behalf of. So I do want to make that really clear that if there was somebody who is nationally certified in North Carolina that never ever trained with us, what we would say to a managed care organization is we think that they should also have a cost-based reimbursement based on the fact that they are nationally recognized. Okay, so how do we do this work? I think really the core thing for you all to think about as you're going about tackling these issues in your states or in your catchment area is, first and foremost, who is the person or the people who get to in terms of rates, and then in terms of procedures, billing, encountering, et cetera. If we're talking about the Medicaid program, obviously every state Medicaid office is contracted through CMS and has requirements about Medicaid in particular. But with the waivers that increasingly exist in states and Medicaid sort of transformation with the 1115 waiver, there's a lot more flexibility for managed care organizations and states to reinvest their cost savings or to spend their money in ways that are not typical in order to move towards outcomes. So I think we've really capitalized that in North Carolina. In terms of that first bullet, like identifying the decision makers, our managed care organizations are the ones that contract with the networks of providers and are able at the MCO level to go ahead and set rates, establish billing codes, et cetera. I will say in North Carolina, we have 7 or 8 remaining MCOs that covering 100 counties. We've had a lot of consolidation. We're down to 7 or 8 of them, and each of them operates differently, has different focus, has a different level of investment in EBTs. So we do not have uniform group that we can go to or a central group for the entire state. We have to go MCO by MCO and get a variable response. So I do want to be clear about that. What we advocate for is cost-based reimbursement, whether an agency is for-profit or nonprofit. What does cost-based reimbursement look like? And the goal of thinking about cost-based reimbursement would be the vehicle to moving the population towards outcomes and cost savings. When you do this advocacy work, there's sort of like a checklist of things you have to have in mind that you go armed with when you meet with these folks. And basically, one thing that you also have to be committed to in your mind that it's not like a one-time thing. A managed care organization might not necessarily be an expert in EBTs in general or a single EBT specifically, certainly not at the clinical nuts and bolts level. So sort of on the level of the advocate, you are committing to being clinically informed, knowing what your own lane is and staying in it, and being able to articulate in a technical way to a managed care organization the way they want to receive the information in a way that is EBT specific. So the conversation I would have about PCIT looks very different than like a psychodynamic model like CPP, for example. So thinking about the actual model as you go in to talk to your decision makers. The other thing that's helpful to bring in where it's available is performance data, and by that I mean the clinical workforce. Are you measuring integrity or fidelity? Can you talk to your MCO about how an agency or a training cohort or a population of clinicians is performing from an integrity or fidelity perspective, for example? Clinical outcomes is obviously what they care about. So are you doing pre and post treatment assessment? In North Carolina, when we train around PCIT, in addition to, like thinking about things like DPICS and ECB, we also, for example, do pre and post treatment trauma assessment. So this is sort of important data in terms of outcomes. And then in the ideal world, which we have not gotten to yet, there'd be like long-term follow-up that you'd be able to present with your own data. Obviously, there's research data we can turn to, but in terms of an MC, I'd like to know that their own local population is responding like a national sample would. Any service utilization or cost data, I think, is extremely important. And any return on investment data, like if we can turn to Washington State and the data that they collect around return on investment and time to ROI, et cetera. So there's sort of things that you can bring from the national environment to share with your MCO or your decision makers. One really key piece that I wanted to actually share was the idea of a time model. Early on with TFCBT, we got in a little over our heads, or we got out of our lane anyway, and that was we spent a lot of time figuring out the time model for service delivery for a single case. Like, what does it take to deliver TFCBT to a typical kid? And we spent a lot of time looking at average salaries, attrition, vacations, that kind of thing, and came up with our own cost model of the cost of delivering TFCBT. The actuaries at the MCOs were not pleased with that idea, like that a bunch of clinicians and pediatricians had spreadsheets and were doing this work. So they did like the idea, however, of clinically driven time models. They want to be informed about what a typical case of PCIT looks like, what is an acceptable range in terms of all the service delivery requirements, both in and out of a clinical session. And we've done elaborate work around that, and that's something that's much bigger that we'd be happy to follow up with. And then finally, if a managed care organization is going to commit to higher rates, for example, cost-based reimbursement, and they're taking advice from you about what network contracting language should look like around, what is high quality PCIT, for example. They're going to want to have some sort of tool or way to understand that the network continues to perform well and that the outcomes are being tracked and the outcomes are good. And in the case of our program, we are developing this web-based tool to do that. Next slide, please. I spoke about this already, so I won't get into it a lot, but this is a nod to that idea about we have developed this clinical service delivery time model series. So it's not cost modeling, it is time modeling. What does it cost in terms of an agency's efforts to deliver an EBT to a particular kid at a typical case? And also, is there a range? In the models, we are currently using data, but our goal is we're actually starting to move towards counts, at least during our cohorts, that would allow us to have real data versus expert estimates. And again, this is accounting for the things that happen in session and out of session. Next slide. So I think this is important for you all to think about in terms of what ways to achieve cost-based reimbursement, because it's not like a straightforward dollar thing. There's various strategies. So I want to emphasize again that I'm not an expert, but this is just sort of what we have been doing in our state and ways that we have approached this issue. And again, it varies from MCO to MCO about what's useful to them, because ultimately they're the drivers. But certainly, even though we have technically managed care organizations, people are still paid in the state on a fee-for-service basis with a rate that's fairly low. And so we have been very successful with some of our managed care organizations, and just simply for our rostered PCIT clinicians or for nationally certified clinicians, having a higher rate tied to a specific code for their fee-for-service billing. So that is definitely one strategy. Another strategy is to develop an actual case rate. So for example, in North Carolina, MST is not one of our models, but there is a $19,000 MST case rate that has been established. And so that's sort of one way to think about getting an EBT paid for. It's an efficient way to do it with monthly billing to justify the drawdown of those funds. Another way to think about EBTs and getting paid appropriately to do them is to take an evidence-based model and really advocate very hardcore to get it dropped into another service definition other than just traditional outpatient services. So for example, in North Carolina, PCIT is one of the models that has been incorporated in some MCO catchment areas in the intensive in-home package. So intensive in-home services is a team. They offer more, there's a higher rate of billing available through that. And we're advocating really hard that if you're going into a home to deal with a family that's got behavioral or trauma issues, you should at least be offering an intervention that has an evidence base at its core. So clinically, that's the appropriate thing. And the nice side effect is there's a higher billing rate to do the service in that context. The other thing is there's other services that go along with EBT delivery. For example, in our state, case management or high-level clinical assessment are not billable codes. The codes have existed, but like if you build them, you wouldn't get any money. So we have been successful in some of the MCO catchment areas to get some of these services paid for that augments that particular PCIT case, for example. Next slide, and I think it might be the last one. This is the last one. So I don't want to overwhelm you, but sort of it comes down to dollars. And so what I did was, just to orient you to this slide, I'm trying to show you that we have achieved differential reimbursement rates in North Carolina. The goal is to move to actually cost-based reimbursement, where an agency retrieves or gets what it costs them to operate and deliver the model. And so the far left column shows you like sort of the different kinds of ways PCIT or another EBT could be done in terms of child-only sessions. There's two versions of child-only depending on the number of minutes, sorry. There's a caregiver-only, and then there's sort of a joint or conjoint session. And so the top headings, what you'll see is one of the managed care organizations that I just called MCO number 1. And so what we have is the standard reimbursement rates to do treatment through Medicaid program for MCO number 1, if they were just doing PCIT the old way. By going in and advocating for cost-based reimbursement, that second column talks about the enhanced rate, and you can see that there's sort of considerable difference by using these modifiers for a person who's contracted in their network based on their training or their background. So the two green columns show just like MCO number 1, and that same clinic that I got this data from was also willing to show that they are actually under contract with a second MCO that's nearby. I said that we have 7 or 8 in our state. So one clinic has taken the time to contract with 2. Same PCIT model, the same clinic, the same clinicians, just the kids happen to have a different managed care organization like managing them. The rates and the actual modifiers and codes are very different. So this, the billing person I spoke to in this case talked about what a hassle it is to know the different rates, same kind of kids, and figuring it all out. You know, just working with more than one MCO, it's kind of a drag. But you see the vastly different reimbursement rates when you look at a standard reimbursement versus the enhanced. I will also say enhanced rate is not favored by anyone. The true goal is cost-based reimbursement, but in the absence of fully achieving that, we sort of need some language in the middle. So an enhanced rate is what we go with, but it really is like a turn off to lawmakers and enhanced. So cost-based feels fairer. But I just kind of wanted to share this information. I think that's my last slide. Pretty sure. You want to just look at the next one? Yes. So that was sort of it in a nutshell. I hope that's useful, and I'm going to be here for the entire call if anyone has questions at the end.
Thank you so much, Dr. Hagel. That was a lot of information and really amazing to hear about what's happening in North Carolina. And for people who are just on their phones, we can share sort of what this slide looks like, but it's showing that rates can really vary for the standard cost of, a caregiver only session being $65 up to $126, depending on the MCO that is being used. So great information here. So we're gonna move on to hear about PCIT across Pennsylvania, and we have two wonderful speakers. We have Sherry Schaefer, who's the Senior Director of Program Operations for the Community Care Behavioral Health Organization, and Amy Herschel, who is the Early Childhood Innovation Center and Associate Professor at West Virginia University. So I'll pass it over to you guys.
Well, good afternoon, everyone. It's Sherry. And Amy, you want to introduce yourself?
Sure thing. Good afternoon, everybody. This is Amy Herschel. I wonder, Sherry, if we should, I really love the idea that we're hearing from different states, because it's so interesting to me how it seems like what's been happening with financing has been impacted by how programs grew, or how PCIT kind of grew across the state. So I wonder if we should give a little background about that and give folks a little bit of information about who we are. What do you think?
Yeah, that's a great idea, Amy. I was thinking that we could give a little context for Pennsylvania. So I'll start on the managed care side. So Pennsylvania operates in a carve-out model where behavioral health services are carved out of the physical health managed care organizations across Pennsylvania. And we are a Commonwealth. Pennsylvania is a Commonwealth with 67 counties. And each of those counties has the opportunity to choose their own managed care organization. And Community Care, the organization that I work for, is the managed care, behavioral health managed care board for 39 counties in Pennsylvania. So we're, like North Carolina, there are a variety of other MCOs. So I'll represent from Community Care's perspective, but I think a lot of the approaches are common across the managed care organizations. And Amy, maybe you could talk a little bit about how PCIT got started and spread in Pennsylvania.
Sure. So now we have developed PCIT programs in 62 out of 67 Pennsylvania counties. And so we've developed programs in over 120 outpatient programs. Sherry and I will talk a little bit about some of the work that we've been trying to do to embed PCIT principles within the BHRS service line. So a community-based in-home approach, and we've done that in 4 counties. And so we also have trained in PCIT over 300 clinicians. And so we did pretty quickly. So in the course of maybe 8 years, which sounds like a lot, but really isn't when you think about how you have to kind of grow things over time. So we started with different funding sources. We were very grateful to have funding from foundations and from MCOs for training, just to train clinicians in PCIT. And then we were fortunate enough to get a couple of small grants along the way, and then a large grant from the National Institute of Mental Health to do a study to understand implementation approaches across Pennsylvania. So that's kind of what has helped us to build up. And I will say our work has been very collaborative, and we'll talk about that in just a few minutes. So while it's tough to say, which where the PCIT work has lived, so to speak, because it has been out of different settings. So certainly there's been some university involvement, but MCO involvement, state level involvement, and we've been grateful for those kind of partnerships.
Okay, so
I think that's good, Sherry.
I think that's a great. That helps give a little bit of context in Pennsylvania. And I'll also share that Pennsylvania is a Medicaid expansion state, so we've seen a lot of growth in the total Medicaid population. For years, it was always about half of the members we had that were enrolled in Medicaid or medical assistance were children or under the age of 18, and many of them also involved with other systems like child welfare, children, youth, and families. So a little bit more context here. So PCIT is a covered service. It's covered as outpatient mental health services in Pennsylvania. All payers, so Medicaid and CHIP and all the commercial products, cover the service as family therapy and collateral or co-therapy with child and parent. As Amy mentioned, community care is also, with some help of some great partners and consultants, including Amy, have developed and implemented an in-home community-based version of PCIT called Intensive Family Coaching. It is available to Medicaid-eligible children and families. In Pennsylvania, when we say in-home community-based services, or you often heard them as sometimes it's called BHRS or wraparound, it's the behavioral health version of the EPSCT coverage for mental health services for children. So that's the context of the in-home version. We we've implemented the in-home version in Western Pennsylvania and Eastern Pennsylvania, and really because we had a critical mass of PCIT trained and experienced clinicians and quite a few level 1 trainers, and that were part of organizations that offered also offered the in-home service version. So we sort of paired those things together to create an in-home version. Next slide, please. What do we do? What rationale do we use to pursue enhanced rates? So in Pennsylvania, the Medicaid Managed Care Health Choices programs are able to negotiate and offer enhanced rates to qualified providers of specialty care like PCIT. That includes evidence-based practices. PCIT is just happens to be one of them. Community care, which is part of the University of Pittsburgh Medical Center Insurance Service Division, offers enhanced rates to qualified contracted outpatient providers for PCIT. And the rationale for offering a higher rate, which of course we've covered already, is really it's a higher skill level. Clinicians are required to be licensed mental health practitioners. Of course, there's an increased amount of time spent in training and supervision and fidelity monitoring, as well as the work with families and other service systems for children and families that are served. But the general rationale as well is that while this service may be costs a bit more now, we're hoping that there's lower cost of care. We're really preventing children and families from entering into more restrictive levels of care over time, and that's to be determined. We haven't been offering PCIT on the Medicaid side long enough to really know to follow children over the long term, like for the rest of their childhoods, but that's an expectation. One of the other things I'll share too about this being covered as an outpatient service on the Medicaid side of Pennsylvania is we're also required some partnership and work with the licensing entities from the state who license outpatient clinics. And in particular, Pennsylvania's licensing regs for outpatient are progressive in some ways in that they do need seclusion and restraint as part of the service delivery. And Amy in particular had to do some work with our licensing folks to help them understand the timeout component of PCIT in the context of the clinical treatment, and to not ding providers or still permit timeout to be used in outpatient clinics. So it took a little bit of work in doing, and some differences we had to do in PCIT playrooms to make sure that those setups were safe and that the adults had a view of the child in timeout. Next slide, please. We use enhanced rate methodology. It is, as we heard earlier, it's probably one of the simplest ways to get higher reimbursement to PCIT providers. It was really designed, it varies by our contracts. The counties, really each of the counties have control over their fee schedules and can determine and prioritize services for higher enhanced reimbursement rates. Where as PCIT is spread across Pennsylvania, though, this is one of the services that I think all the managed care organizations in Pennsylvania have come to value, and most of us offer some sort of enhanced rate. And that's, again, it's to cover the cost of clinical supervision and fidelity monitoring. Staff have been trained in PCIT through different funding mechanisms, as Amy mentioned, through grants that continue. And for providers who don't have really experienced internal trainers for PCIT, we use various funding mechanisms and grants to help continue to train to keep an adequate workforce here. And for the in-home version, we're planning for similar rate enhancements for credential providers of the in-home version. And that's attached to completion of training, participation in a learning community with community care and our consultants, completion of some skills and fidelity checks, and the graduation of the organization of 6 IFC cases, or intensive family coaching cases. Next slide, please. So what steps do we take to move forward? I think this is, I'm handing off to you now, Amy, to talk a little bit more about what we've done in Pennsylvania to sort of get PCIT going and what we're plans for sustainability.
Sure thing. So one of the things that I think we're most proud of is that we, in Pennsylvania, from the very beginning of the development of PCIT, we included partners. So it wasn't necessarily group pushing things forward. Instead, it was more of a collaborative effort. And so from the very first meeting, or the very first small little grant we had, it was actually a foundation grant. We started getting groups together to talk about, we essentially thought about like who might be affected by the implementation of PCIT, and from everything from referral sources to the outpatient provider to the funders from the foundation and from the managed care organization who would support the clinical service, by paying for the service. We got them all together and started talking about how this might look as it would be implemented in the community. And so I think what that has done is that because people were involved from the beginning, it has shaped the work so that people are, I'm very grateful that they continue to be invested. And so we've kind of nurtured, as we said here, champions of PCIT across the Commonwealth. Could you please advance the next slide? And so we tried to organize our slides around the questions that we were tasked to address. And so when we thought about who the key players were that needed to be involved in the process, there were a lot of key players. So we were fortunate. First, we had a steering committee at a county level, and then as we kind of went on and as we expanded our training off across the Commonwealth, we grew what was at a county level to a state level. And so we've had a statewide steering committee for PCIT implementation in Pennsylvania for about 6 years, a little over 6 years. And on that committee, we have had key leadership, really decision makers. And essentially, we get these decision makers together in a room. In the beginning, we met quarterly and then would have a little bit of communication in between those meetings. And as time has gone on, we've had we've had probably the meetings where we went from quarterly, like 4 a year, to 3 a year, to 2 a year. And we're currently sitting at 2 a year. Just to keep people, we make sure that we schedule them in a way that we're keeping them, the content of the meeting really full, because these folks are so busy and have so many competing demands. We're just really grateful that they continue to give up a full day to come and meet together. And so we have folks on that statewide steering committee from county, state, and, as you can see on the slide, state and county mental health, child welfare, managed care organizations, early education, school districts, behavioral health treatment providers, clinicians and administrators, and then families of young children and their advocates. And so you can see on this slide, these are pictures of one of our recent meetings. So what happens in this kind of process then is that you get the benefit of seeing the implementation from different perspectives, and seeing how and being able to respond to the needs of the full community. And so I think this piece, I don't think can be appreciated, emphasized, because it really has helped to push the work to be more collaborative, and then everybody is invested rather than one group or one program being invested. And I think what we have learned over time is that it really does take a pretty substantial effort of a lot of folks, and particularly key decision makers, to make sure that you can implement PCIT, but also sustain it. And part of sustaining it is financing it. And so we've been very grateful to have the support of funders within Pennsylvania. So if you could do the next slide, please. And this is back to you, Sherry.
Yeah, so this is just the simple answer to how we pay for PCIT, and it's as a modifier to family therapy. That's the gist of it, very similar to the experience in North Carolina. And not only does the modifier, it's a pricing modifier for from the managed care perspective to pay a higher rate, but it's also a modifier, an information modifier that helps us identify children who've received PCIT for program evaluation activities. Next slide, please. Back to you, I think, Amy.
Okay. And so in terms of what we're up to now and what we're planning for the future, we have been working really hard to make sure it's one thing to implement. It's hard to implement across the state and to get a full workforce trained. And we feel like we have done that. There's still a need for more training, believe it or not. So that's part of it. But I think the challenge that we are now facing is how that work over time, because there's a lot of fluidity in the behavioral health workforce, a lot of innovation, thankfully, on the PCIT side. So we're just trying to make sure that we have the infrastructure in place to be able to continue to ensure that PCIT is delivered in Pennsylvania, and it's delivered with high quality. We have also experienced a couple of dilemmas now that we have this broad scale implementation, and those two dilemmas that maybe some of you might resonate with are that we still have this dilemma around underutilization, that there are many more children in the community who could benefit from PCIT who do not receive it. And that is a complicated topic about what, but we have been trying to do more to ensure that, the old saying, like from the old movie, if you build it, some of that is true, but not all of that is true. And so now we are trying to make sure that the kids who need this are getting actually access to the services. And the other thing that we are working on is just how to address rates of attrition, because sometimes we can get children to PCIT, but unfortunately not all the families graduate from the model. And we really want to make sure that in Pennsylvania, if children, parents of children with who could benefit from PCIT want PCIT, they can get it, and that they engage in the treatment so that they can graduate and get those great clinical outcomes. So those are the things that we are working on now, and we're grateful that we can do it in the context of having enhanced rates for outpatient and in-home service, PCIT services. All right, I think we did our 20 minutes. I think we got our timing down.
Thank you guys so much. So right now, for the audience, those North Carolina and Pennsylvania are the two states on the call who have already gone through the process of getting cost-based reimbursement or enhanced rates. And now we're going to move over to hear from Minnesota and Oregon, who are within this process and also are going to address more how you do CPT codes and claiming just from within their system where they haven't had that happen yet. But before we move on, if people have any specific questions for the past three presenters, you can go ahead and just take a quick question and answer break. Well, in that case, let's move over to Kathryn Wright, who is the Early Childhood Mental Health System Coordinator in the Minnesota Department of Human Services.
Hello, my name is Kathryn. Hopefully you can hear me. And just know I'm in a cube, so sometimes it gets loud. I apologize if you hear other voices. Okay. So I should just start off and just say a little bit about myself. I'm a licensed psychologist and also a clinical counselor, and I've been here at the state for 10 years, but I'm really lucky in that the state allows me to still practice. So I practice 1 day a week with children birth through 12 in a community mental health center. And one of the things I will say too is, that's not on the slide, I only have one slide, but I will say a little bit more kind of in reflecting on what the others have said. In our state, we have had a concerted effort to try to get clinicians across the state certified in evidence-based practices. And my job here has been to develop an early childhood mental health system of care. So I will say the interventions for young kids that we support and have been supporting are PCIT, certainly, and actually we've been supporting that one, I want to say, for almost years. We also support child-parent psychotherapy. We support attachment biobehavioral catch-up, and then for older children, trauma-focused CBT, and a program called Managing, gosh, it used to be called PracticeWise. I'll have to look it up again about what it's called now. We call it MAP, but I can't remember what the acronym is. I'm in charge of the 3 early childhood ones, so PCIT, ABC, and CPP. And I should also tell you that I am certified in all 3, and I get to practice those in my work outside of the state. Sorry for the background noise. Couple things that we've done as a state to help support our clinicians is we really value people getting certified, and so we actually pay for their lost productivity time to go through the certification process. And that I support, I actually have folks apply, and if they don't finish and get certified, they have to pay the state back $5,000. And I was thinking we've made some choices around that just because we offer these trainings all for free, and we've added those components in there because we oftentimes would have clinicians, and I would say especially around PCIT, who it conceptually did not fit with their theoretical orientation, and so they drop out in the middle, and we would lose a clinician and also lose a spot, and then lose a lot of resources. So that's one of the things that we do to build the system. The other thing that we do as a part of our strategy, I should say, is that for those 5 evidence-based practices I talked about, my colleague who does the older children's outpatient services and myself, we worked with clinicians across the state to figure out basically how much it costs per clinician to get them certified in the intervention. So so clinicians and agencies can help plan for that when they're thinking about sending somebody through. The other thing that we try to do as a strategy as well is to build, at least for PCIT, level 1 trainers in agencies, so that so clinicians don't need to keep coming to the state for training, but instead they can get it from their own agency. And I would say in the past about 8 or 9 years, we have trained 22 level 1 trainers in PCIT. I'm one as well. And I was just looking on the website for PCIT, and I know it's a little bit behind because there's more certified level 1 trainers and certified clinicians that are up there. But similarly, to become a certified clinician, you also need to sign a contract, and if you don't finish the requirements, you need to pay the state back because we do it all for free. Another thing that we do to help build our workforce is I manage and facilitate a quarterly level 1 trainer call so that all level 1 trainers across the state, whether they're certified or not, can have conversations about how are we growing our population of clinicians, who's a good fit, what are the clinical issues that people are running into, and how does that work across our system. And then the other thing that we have done is we also have a level 2 trainer in our state, and every 2 years the state pays her to do a full day training, so all of those folks that are certified can get their CEUs to keep their certification. So I'll just say those are some of the supports that we've been building into the system to grow our population. And on the website, it looks like we have 42 certified clinicians, so I know we've trained and have probably many more that are actually certified. So those are kind of how we've been growing our population. Currently in Minnesota, clinicians can bill PCIT as family psychotherapy or family psychotherapy without the client present at a 90846 or a 90847. Couple things to say about our Medicaid system here. Our Medicaid services for mental health for children are actually a part of EPSDT. So if the child qualifies for mental health services or has a medical necessity for mental health services, they can receive it. I will say a couple other things. I actually saw one of the questions about 90846. 90846 actually is a billable service lifespan. So it starts at birth and it goes throughout the lifespan, as is family psychotherapy. So that's maybe a little bit unique in Minnesota. The other thing I was thinking about cost is when North Carolina was showing the actual reimbursement, I think Minnesota has a pretty healthy rate reimbursement, and this is public on our website. So for a 90846, the rate is, depending on what kind of provider you are, is either $96 or $123. And similarly for a 90847, it's up to $128. And then some clinicians do bill the 90837, which is the 60-minute psychotherapy session. And there's been conversation back and forth about what is the definition. I think when the CPT codes took it off as no longer being just individual psychotherapy, but psychotherapy with or without collaterals. That one pays really well, up to $153 an hour. So those are some of the things that we think about financially. We currently do not have an enhanced rate for PCIT. However, we are in the process of completing a rate study to identify both the costs of not only being trained, as I said, we are starting to figure that out, but also providing the cost of providing PCIT and those other evidence-based practices so that we can make a case for an enhanced rate. And I will say, I'm not sure what's going to happen here within our state about how enhanced rates go. There's been a lot of conversation about paying for performance, paying kind of a bundled rate, and then we're very much a fee-for-service state, so does it make sense to have a modifier and just pay a higher rate? And part of what some of us have been thinking is we really value national certification, so maybe the only way you get that is if you're nationally certified. So those are some of the conversations that we've been having within our state, but currently don't have any, we don't know exactly what's going to happen, and that'll have to go through our legislature. So that's pretty well all I have.
Thank you, Kathryn.
Yes.
I'm going to move over to Laurie if she's on the call. So Laurie Teodoro is the Early Childhood Mental Health Policy Specialist with the Oregon Health Authority.
And yes, thank you. Can you hear me?
We sure can.
Oh, that's fabulous. I've had all kinds of technical difficulties. I'm out of town and I am now sitting in my car. So if you hear doors slamming, I'm fine. It's next door to me.
Okay.
Yes, I'm the Early Childhood Mental Health Specialist on the Child and Family Behavioral Health Unit. And I, like Kathryn, am one of my tasks is to oversee the development of an effective early childhood system in the state, and majority of my time is spent overseeing a legislatively assigned pool of funds to expand PCIT throughout the state. I've been at the state for 4.5 years now. Previous to that, I was a PCIT therapist and trainer in both county mental health program and in private practice. And we have PCIT both in private practice, but the majority of the PCIT provision in Oregon is through is for Medicaid eligible children and their families, because the state has been supporting PCIT since an initial pilot grant in 2004, then there was an expansion in 2009, and then another expansion in 2013. The grant funds are for program development, so there are PCIT programs in 19 of our 36 counties, 45 physical locations. We see approximately 1,500 children a year in PCIT in agencies that serve Medicaid eligible families. One of the great things my predecessor set up were quarterly reports to any program that receives our funding that report some demographics on the families, pre and post scores, number of sessions that they attended, whether they made improvements, not, whether or not they graduated, but also just whether or not they improved in other ways besides the ECBE scores. And that data shows that 85% of the families who participate in at least 4 PCIT-specific sessions, so that's not including your initial intake assessment process, but from the DPIC forward, 85% of them show improvement. Their ECBE scores drop at least a standard deviation on average, and the effectiveness rate for those families, even if they do not complete PCIT, is 0.72. The overall effectiveness rate in Oregon is 0.88 if you average all the families together, those that graduate and those that don't. So those kind of statistics have really been helpful over the years to continue support for PCIT in all venues, so that we can award grants for free training, for program development, such as the room build out, administrative time, time for the supervision and consultation, ongoing, etc. Oregon is a little different than, or a lot different than most states, in that we've had a Medicaid waiver for quite a while now, and our Medicaid system is based on something called the Oregon Prioritized List of Health Services. It is managed, this list is managed by a commission that is legislatively appointed, and they were tasked in 1994 to create a list of all things which might require medical intervention for a human being of any age, and prioritize them in terms of the most important diagnoses to treat and what services should be paired with that diagnosis. So the first one on the list is pregnancy. If the state didn't have any money to pay for anything else, we would take care of our pregnant women. And way, way down on the list, like line 667, is ingrown toenails, for instance. And so every biennium, the legislature draws a literal line on the list which designates anything above the line is reimbursable and anything below the line isn't. And that line is determined by how much money we have in that biennium. And that way we, putting people on and off the list, we're just covering more or less diagnoses. So in order for this to work, in order to receive Medicaid services, the child has to have a diagnosis. And that actually, harking back to some of what the other presenters have said, that's actually been a barrier because of concerns about giving young children diagnoses and about children being turned away from services because they didn't have a mental health diagnosis in the traditional sense. So what the commission that oversees the list did was, with guidance from the early childhood work group that I facilitate, is they put some codes above the line tend to be particularly useful for treating young children, like parent-child relational problem is a primary diagnosis. Abuse and neglect is a primary diagnosis. Other severe stressor related to the primary support group is a primary diagnosis, and those would qualify children for PCIT. We also have 15 coordinated care organizations which are in charge of all the Medicaid funds for their members for physical health, mental health, behavioral health, substance use disorder treatment, and oral health. And those funds are pooled, and the CCOs can use them as they see fit to help their members achieve better health while spending less money. And they can choose to reimburse providers at a higher rate for certain things than the state does if the provider bills the state fee for service. So, but they can't pay their providers less than what the state would pay if the providers billed the state directly. So that gets us to how we bill in Oregon. And just like in Minnesota, most PCIT in Oregon is billed under family therapy, either with the family member present or without. However, it is possible some providers do bill for psychotherapy for 45 or 60 minutes, whichever is more accurate for the particular session, for the coaching sessions. They can't use the psychotherapy codes for the didactic sessions because the client, who is the child, needs to be at the psychotherapy sessions. Now, the reason why some of the, or many of our PCIT providers do not bill psychotherapy, even though it pays about 20% higher than family therapy, is that some of our CCOs, our coordinated care organizations, use case rates or capitated rates. And so that's the caveat to that, is that if they need to really work with their CCO to make sure that they will be reimbursed enough to cover a full course of PCIT.
Do you want to address the interactive complexity code too that you have on your slide?
Yes. Thank you. My phone just, I had to put in my password again as I'm looking at the slides on my phone. So the interactive complexity code, I'm not sure how many of our listeners are familiar with it, but it is an add-on code to the psychotherapy code that can be, if you were going to use it, you use it in addition to the psychotherapy code, and it provides a little bit extra funding, not very much. For physicians, for fee-for-service here in Oregon, it only adds another $10, but that can add up over time if you have a lot of clients. Now, it is not the interactive complexity code 90785 is not available to providers who are billing the state directly, but some of our CCOs do allow behavioral health providers who are master's and doctoral level to use that code. And what it is that it's a bump up in reimbursement for factors that would make the session more challenging and require a higher skill level. And the things in the CMS manual, the CPT manual by CMS, that it lists that would qualify it would be the need for the clinician to manage maladaptive communication, high anxiety, high reactivity, etc. among participants in the session. Caregivers' emotions or behaviors that interfere with the ability to assist in the treatment plan, a disclosure of abuse or neglect, the use, and this is particularly important for PCITers, the use of play equipment or other physical devices or equipment in order to conduct the therapeutic session. The other one, the other condition that would make this particularly appropriate to PCITers is that it's also used when the recipient of the therapy is too young to be able to communicate verbally well or is not talking yet. So you can see how if your insurer will allow the interactive complexity code with the additional documentation of the conditions that qualify that code, then all of your coaching sessions can be billed with the interactive complexity code. And so when I've done the math on this for an average duration of PCIT of 20 sessions, if you use the psychotherapy for 60 minutes plus the interactive complexity code for all coaching sessions, and you use the family therapy codes without client present for the didactic sessions, the total reimbursement for an episode of care would be about 32% higher than the way we traditionally bill PCIT. But again, it depends on how you're working with your insurer or your payer to make sure that that actually is allowable according to their rules.
Thank you so much, Laurie. And I think that brings me to a very important point that I should have made at the beginning, but also to reiterate to anyone else who wasn't here at the beginning, that all of these speakers, we really wanted to put this panel together to highlight the complexities and the steps that can go into the thoughts behind reimbursement and claiming. And none of these are specific recommendations about what you should be doing in your practice, but more considerations of ways that you might approach this in your state or within your organization, because I think it's become abundantly clear that things vary not only from state to state, but even within each MCO or CCO.
Yes, thank you very much. So the next steps that we are working on is, of course, we are continuing to grow our PCIT workforce. Right now we have approximately 105 clinicians across the state who are actively providing PCIT. We've probably trained twice as many as that, but of course they've moved into supervisory positions or been reassigned to other positions, and that is actually, in our view, a bigger than clients not completing PCIT, because what we're finding is even those that don't complete PCIT, families that don't complete PCIT, benefit from PCIT more than they would treatment as usual and more than most other child therapy. The key, though, is to keep the workforce, and they are quite fluid, as one of the other presenters stated. The other thing that we are doing is that we have the Oregon Health Authority leadership is on board with advocating for continuing the legislative funding for the expansion of PCIT, but also we've recommended to the governor's cabinet that we get to do what Kathryn is doing, which is a rate assessment, so that we can, the next step after that would be recommending a cost-based payment, that so instead of grant-based program development and training, it would actually be built into a higher reimbursement rate for PCIT. We have involved our contracts unit in making sure that all of our contracts to PCIT programs or programs that want to start a full fidelity PCIT program require data collection, fidelity reviews at least once a biennium, and ongoing training and supervision. We strongly encourage PCIT International certification, because in order to do the eventual goal, which is cost-based payment, we need an outside national entity to be determining who is eligible and who isn't, and then we will need to have a PCIT modifier and a provider list that our billing software can check against, so that we're only paying for PCIT by those clinicians who are adhering to fidelity. And one of our big reasons for looking at cost-based services is because we have the workforce in our most populated counties. We get great outcomes, but we still run across agencies who still have more children in standard individual non-directive play therapy who are in the PCIT age range than who are being referred to PCIT or CPP. We do have CPP in the state. And when you dive into that, it's because psychotherapy is being billed for those individual sessions and they get paid more for it. And so we really want to incentivize doing evidence-based practices as opposed to standard non-directive play therapy because of the outcomes we've gotten since 2004. And I think I'll stop there. I've talked more than my 3 slides, I think.
We've appreciated all of it. So we will open it up now for questions for our speakers. Like I said, things might be different on a state-to-state level, but we will do our